Thank you very much. So I'm going to give a fairly broad overview of this enormous topic. I will refer to some historical aspects. I hope to give some feeling about current research on the microbiome, and I will spend some time talking about clinical implications in terms of diagnostics and prognostics. I will not talk about the microbiota in IBS because the next speaker is going to deal with this, and I will say just a little bit about therapeutic possibilities because of time. Now, we talk about the microbiome revolution, and in fact, a lot is written about this. And indeed, there has been an explosion in knowledge of the human microbiome, all the way from fetal life through childhood to adulthood and to later life. However, there is a lot of data out there from the early literature which actually taught us a lot about the microbiome. And I've chosen a few of these. One, of course, is a very important one, which is enteric infections and infestations. But that's an obvious change in the microbiome. But several years ago, a very important aspect of the microbiome, its interaction with the immune system, was recognized with the description of reactive arthropathy and uveitis in individuals who are HLA-B27 positive, and very interestingly, the relationship between Guillain-Barré and Campylobacter pylori. Helicobacter pylori remains one of the few diseases that we can link directly to a single organism. And antibiotic-associated diarrhea tells us what happens when we disrupt the microbiome. Small intestinal bacterial overgrowth, we've already discussed here at this meeting, and of course, there are important issues with the gut microbiota and the liver. Now, the relationship between Guillain-Barré and Campylobacter jejuni was actually first described in 1982. And it was noted that about 38% of cases of Guillain-Barré were preceded by Campylobacter jejuni infection. And those cases actually had a worse outcome, with a greater likelihood of respiratory support and residual disability. But the real breakthrough came with the recognition of the relationship between the infection and the development of antibodies against the nervous system. And you can see here the time course of the syndrome, and it's tightly related to the development of these antibodies and comes after the actual infection. And these in more detail show you these antibodies which are directed against gangliosides in the neuron. But here's a beautiful example of cross-reactivity, of an antibody being developed against a bacterium which cross-reacts with a part of the body. This is important because there is evidence that this may also apply to primary biliary cholangitis and to primary sclerosing cholangitis. Now, Helicobacter pylori, which is a favorite topic of Henry's, is a truly old infection, as we know. And this is one of Henry's mentors. This, as you know, is Utsi. And one of the things that came out of Utsi was that this poor individual was not only murdered, but actually had Helicobacter pylori. And indeed, using modern molecular techniques, they were able to trace where his Helicobacter pylori came from, and indeed this disputed some of the previous data on the geography of Helicobacter pylori. And Helicobacter pylori, perhaps more than any other bacterium, has really taught us about the intricacies of the interaction between the host, environment, and the bacterium. And basically, this interaction, which is partly genetically determined, leads to the outcome, be it ulcer, gastritis, or even cancer. But I want to share with you today a new Helicobacter organism. You've heard of many other Helicobacter organisms, but this is a new one, H. Cohenitsky. This can be found all over the world, but it's especially prevalent in a small country in South America. And indeed, recent outbreaks of this organism have been seen in Turkey and in North America. And I'm very worried about India because it may have an outbreak very shortly. It was never found in Ireland. But it's an important commensal. It supports the growth of those around it and enhances the well-being of the entire organism. But there is a negative part. It's very persistent and it cannot be eradicated. Now, more serious. Now, antibiotic-associated diarrhea, and particularly pseudomembranous colitis, due to Clostridia, were recognized, as you can see here, over 40 years ago. And this is really a modern epidemic. And this is data from the US showing the dramatic increase in the occurrence of C. difficile-associated disease, in particular among the elderly. I don't know what it's like here in Uruguay, but in the United States, this is a disaster in our hospitals in terms of reinfection, readmission, reinfection, readmission. And we have learned, actually, some very interesting things about the interaction between the normal microbiome and the predilection to C. difficile-associated disease. And certain bacteria, such as this C. scindens, are very important as parts of the normal microbiome in preventing the occurrence of C. difficile infection. If they are lost, then C. difficile gains hold. Now, this is a very, very old paper from what's over 100 years ago, talking about the bacteriology of the human digestive tract, and indeed emphasizing the role that normal bacteria play in preventing bacterial overgrowth. And here's a later paper showing the important role of bacteria in bile acid deconjugation and conversion. Just one word about microbiota in the liver. This, again, is a paper from a long time ago showing the relationship between plasma ammonia and the development of hepatic encephalopathy. And in this same paper, they actually went on to show the importance of certain bacteria, in particular coliforms, in the development of hepatic encephalopathy through metabolizing protein and methionine, and showed that it was improved by protein restriction and antibiotic, and that oral neomycin produced clinical remission and reduced ammonia levels. So here, in fact, was perhaps the first manifestation of the microbiota gut-brain axis. It wasn't recognized as that at the time, but it certainly was the case. So before we talk about the present or the future, I think we need to remember what we have learned from the past. The normal bacterial communities live in harmony with each other and the host, and there are real consequences to disturbing the normal microbiota, C. difficile-associated disease. The outcomes of bacteria-host interactions depend on bacterial, host, and environmental factors. The example, Helicobacter pylori. Gut bacteria have important metabolic functions and have the potential to elaborate toxic metabolites relevant to bacterial overgrowth and hepatic encephalopathy. And bacterial antigens can cross-react with host tissues to generate immune-mediated disease, the example being Guillain-Barré. Where are we now? In my opinion, the explosion, the revolution, is due to technology. We've seen a dramatic and ever-evolving progress in technology, going from high-throughput sequencing through metagenomics, metabolomics, metatranscriptomics, proteomics, etc., which now provide us the ability to describe complete bacterial populations and their products. But this is only possible because being coupled to an ever-increasing ability of bioinformatics and the power of computing. There are many techniques here that I don't understand. They include network analysis, development of metabolic pathways, machine learning, artificial intelligence, etc. So let's go over some definitions. So what is the microbiome? The microbiome, strictly speaking, refers to the genetic material of microorganisms, but it's often used to refer to the microorganisms and their genetic material. The microbiota, on the other hand, is strictly speaking different. It just refers to the microorganisms. But you'll see, even in the same paper by eminent authors, the terms are used interchangeably. The metagenome is different. This refers exclusively to the collections of genes and genomes, and the metabolome to their metabolic products. This is my simple way of looking at it. High-throughput sequencing, which is by far the most commonly used technique, will tell you in general terms what's there. Metagenomics, which interrogates the DNA, will tell you what they could do. And metabolomics or metatranscriptomics will tell you what they actually produce. Now, I'm not sure if this happens here, but in my practice in Houston, at least once a week, a patient arrives in my office and presents me with a printout from some company that has analyzed their microbiome. And I'm expected to make some intelligent comment and tell them what a great investment they've made. The big challenge is trying to tell them that they wasted their money, because, in my opinion, these tests are currently worthless. Because right now, in clinical practice, despite all the research, the reality is that we still don't know exactly what is normal. Many studies of the microbiome in disease do not account for common confounders such as the patient's diet or the medications they're on. Most of these studies are also single point in time. In other words, they take all of you, they do your microbiome right now, and that's it. They are not longitudinal studies, so they therefore cannot establish causation, and they can't tell you which came first, the disease or the abnormal microbiota. And then, as I discussed yesterday and will not repeat today, there are a whole lot of issues about sampling and analysis that can lead to problems. Just to show you the impact of diet, this is a study from my former colleagues in Cork, which looked at diet on the microbiome in the elderly. And they actually looked at 5 different groups of individuals. Healthy elderly, those who had some disability and had to go to a day hospital, those who were a bit more impaired and had to go to rehabilitation, and those who were so ill they were confined to a long-stay hospital and normal controls. And what they looked at was the relationship between the microbiota, diet, inflammation, and health. And what you can see here are that you can see clearly here that there's a complete differentiation between this group here, who had the high-fat, low-fiber diet, in other words, the poor diet, and those over here who had a good diet in terms of their microbiota and in terms of their healthcare outcomes. This shows it perhaps in the simplest terms, and this is looking at the diversity of the microbiota, and basically the more diverse your microbiome is, the better it is for you. And here you can see here, as you move from the healthy elderly all the way to the long stay, the diversity decreases, and this is accompanied by a decrease in the diversity of their diet. So what this paper, which I think is a landmark paper, showed was that if you eat a poor diet, it's bad for your microbiome, it leads to increased inflammatory markers, and it leads to poor health. This was in the elderly, obviously, but I think it probably applies elsewhere. This has been looked at by others since then, who again saw clear separation between healthy elderly and hospitalized elderly. And you can see here the survival of these individuals was directly related to the diversity of their microbiome. But they identified another factor which was relevant, namely medications. The more medications these individuals were on, the worse their outcome, the more impaired their microbiome. Now, talking about the clinical possibilities of the microbiome, we can talk about diagnostics and therapeutics. And I'll give some examples in each of these areas. This is a recent paper from the group in Virginia who've done a lot of work on the microbiome in liver disease. And what they show here is they're looking at the outcome for people with cirrhosis who are hospitalized. And obviously, their MELD score was highly predictive of outcome, which you'd expect. What you would not expect was that the presence of Enterococcus was also highly predictive of a poor outcome. This is looking at individuals on a high-fiber diet. And what we're looking at here is the ability of a high-fiber diet to improve blood sugar profiles. So here we had healthy subjects who were randomized to either a high-fiber or a low-fiber diet, and their blood glucose profile was evaluated, as were their insulin levels. And you can see here that some of these individuals did not respond to a gluten-free or to the low-fiber diet, and some of them did with the lowering of their blood sugar levels and of their insulin levels. Very interesting. What was even more interesting was that they found that the ratio of Prevotella to Bacteroides was the most predictive factor of their response. And you can see this here, down here, and here. Then they actually took stool from the responders and the non-responders, and they gave them they used it in a mouse model, and again you could see that you could predict the response in the mouse from the ratio of Prevotella. Here's the non-responder donor, no change in blood sugar levels, the responder donor. So you could transfer the benefits of the high-fiber diet to a mouse by giving the microbiota from the humans. Metformin, which is extremely commonly used, not just in diabetes, but in pre-diabetes, causes diarrhea. And there's no question but that the diarrhea that occurs with metformin is due to an alteration of the microbiota. What this study showed, very interestingly, and this is looking here at response to metformin, is that this response can be predicted by the bacterial metagenome. And you can see, in particular, bacterial genes coding for a variety of metabolic pathways can predict the response to metformin. Now, this perhaps is the most amazing finding. And in fact, very recently, with a colleague in Houston, I wrote an editorial about this. This is looking at patients who receive checkpoint inhibitors for metastatic melanoma. The paper we wrote about was actually doing the same thing in small cell lung cancer. So the idea here was whether the microbiome could predict the response to checkpoint inhibitors. And what they found here for 3 different checkpoint inhibitors was that certain bacterial taxa, or the presence of certain bacterial taxa, in blue those that predicted, and in this kind of purple color are those which were negative predictors of response. But basically what they found is that based on a profile in the microbiota, they could predict the response to checkpoint inhibitors. This again is a very recent paper which looked at differentiating irritable bowel syndrome from inflammatory bowel disease. I'm not sure whether you're going to show this or not, Louis. But basically, what has been found in general was that in IBS, there's a higher ratio of firmicutes to Bacteroidetes, whereas the opposite is true in patients with inflammatory bowel disease. And what they looked at here were looking at clinical factors and microbiota factors to differentiate IBS from IBD. Now, obviously, if you just took age and sex and BMI, you saw no differentiation whatsoever. If you added in calprotectin, which we spoke about yesterday in the cases, you saw a good separation. But if you added 20 bacterial taxa, which would differentiate between the two, you now had a very high differentiation between IBS and IBD. But there's still a long way to go. And this is a slide that is impossible to compress, but this is one of 2 very important studies that I'm going to show you, which involved the microbiome analysis of healthy populations in Flanders, in Belgium, and in Holland. And what they looked at is what are the factors that determines why one person's microbiome is different from another. And very interestingly, the number one factor was the Bristol stool score, in other words, your stool consistency. And you can see here there are a lot of dietary factors, a lot of lifestyle factors, and way down here you see disease. The point I'm making is that in a large population like this, the contribution of disease to differences in the microbiome is actually quite small. Most of the differences are due to personal or lifestyle factors. But what's even more important to notice is that, and here's looking at the factors that affected differences in the microbiome. When you put all medications together that came first, you can see bowel habits there, diet, health, lifestyle, etc. But the most important point is that if you took all of these factors on the previous slide together, they accounted for only 16% of the variation in the microbiome. The other 84% we don't know. We just don't know what's causing that variation. This is looking at the Bristol stool score and showing how that predicts for microbiome. This is the other study, which is the one from Holland. Again, found very similar changes. Again, some intrinsic factors, some disease states, dietary factors, and medications, all important. And you can see here smoking even having an influence, which is important when we talk about inflammatory bowel disease. But you see here again the Bristol stool score very high as an important factor. But again, in that study, all of these factors, even put together, explained only a tiny amount of the variation. I've mentioned the microbiota gut-brain axis. The idea here is that there's a two-way communication between the microbiota and the brain influencing each other. I just want to mention one or two things. This is a subject which has been of interest to me for many years. That's Parkinson's disease. This is a wonderful paper which studied a mouse model that overexpresses alpha-synuclein, which is thought to be a critical molecule in the pathogenesis of Parkinson's disease. In this model, antibiotic treatment improved the disease state, and giving the microbiota back aggravated it. Furthermore, if you took microbiota from Parkinson's disease patients, it also aggravated the motor deficits. We've learned a lot about how the microbiota metabolizes our diet, and I've mentioned about its role in predicting drug responses, but don't forget the microbiota also plays a role in drug metabolism. Yesterday I mentioned the release of 5-ASA from asulfidine. It metabolizes digoxin. It produces vitamin K, which may antagonize anticoagulants, and there's now a long list of drugs which are influenced by the microbiota. Here's one, L-DOPA. You can see here Enterococcus faecalis can metabolize levodopa, to dopamine, and another bacterium can actually further metabolize it to M-tyramine. So the status of your microbiota might well influence your response to these drugs. And this is a summary of the many drugs, metabolic pathways that are involved, that the microbiota can perform. You can see it can perform reduction, hydrolysis, deconjugation, etc., all of which will affect the metabolism of drugs, their disposition, their elimination, etc. Now, therapy, there are a range of strategies which I will not talk about in detail. Don't forget diet, antibiotics, probiotics, prebiotics, synbiotics, and of course fecal microbiota transplantation. I want to mention just one treatment study because I want to emphasize that good studies can be performed. This is an amazing study which was performed by Dr. Penegrahi, who was at the University of Nebraska, just moved to Philadelphia, where they did a study which I think was funded by the Gates Foundation, where they studied over 7,000 pregnant women in India, in poor rural areas in India, and they randomized them to receive a synbiotic or a placebo, and they showed that when they followed their infants later in life, those who got the synbiotic had a significant reduction in death from sepsis, overall deaths, sepsis, etc., etc. So they were able to show dramatic increases in survival and also prevention of infection in these infants. So in summary, the fundamentals of the microbiome have been known for some time. What we're seeing today is dramatic and ever-evolving developments in technology and informatics. Together, these drive the current explosion in knowledge and understanding, and there will be more. Microbiota analysis holds promise in diagnostics, and tantalizing hints of this promise continue to emerge. I've shared some with you: prediction of high-fiber diet, prediction of response to a high-fiber diet, prediction of outcome in cirrhosis, response to various drugs. But you need to be careful. Be wary of associations. They do not prove causation. Yesterday we spoke on inflammatory bowel disease about how inflammation itself will change the microbiota. That doesn't mean to say that the microbiota has anything to do with causing IBD. Many confounders hamper interpretation. The Dutch and the Flanders studies that I showed you illustrate this. All the drugs, all the lifestyle factors that influence the microbiota. Microbiota modulation and mining offer unlimited promise, but high-quality trials are few. I've showed you one. It can be done. It's difficult, it's challenging, but it can be done. Thank you very much.